Thank you. Nice to see you again, and nice to see the new fellows. So, as you know, I essentially work at Moffitt, and I've been doing working at Moffitt for 15 years. I just took off the mask so I can speak more freely. So, but I'm okay. I'm not, you know. Okay. So, the respiratory viruses is basically has a lot of viruses, and for what 40 minutes that we have -5 for questions, I decided to include and speak about the most important clinically relevant respiratory viruses for us. So the respiratory viruses are basically divided in different families. We have Paramyxoviridae. Then, of course, in that family, we have parainfluenza. Pneumoviridae, we have RSV and human metapneumovirus, and these two are also included in a subfamily. These two used to belong to this family, but in 2016, they were regrouped in this new family. These two viruses behave very similar clinically. Then we have, in the Orthomyxoviridae family, we have Influenza A and B. And then, of course, we have other respiratory viruses, Rhinovirus and coronavirus, including COVID-19, that I am not going to talk because that deserves another whole hour. And as far as these, the rhinovirus and the other coronavirus, they generally cause mild respiratory symptoms, except in transplant patients, but even on them, the other viruses cause more clinically important diseases. So I will be focusing my time more on those. Adenovirus is also a respiratory virus, but it's also highly complex, especially in transplant patients. It causes hemorrhagic cystitis, severe pneumonias, conjunctivitis. So I also am not going to talk about that one. While I give this lecture, you will see different articles, especially review articles, where you can find more information if you want to dig more into it. It's important about the respiratory virus how they vary depending on the season of the year, especially in the northern hemisphere, and it's not clear why. It looks like it may be related to the weather, the humidity, human behavior, and what's happening in the human body depending on the weather. Sometimes you may have more mucus secretions because of allergies, pollen, again, humidity, and then that makes the virus easier to replicate. And also human behavior, if you are more inside of a space, because it's cold outside, or if you are outside in summer and there is a lot of humidity. So all of these things appear to play a role, and also looks like the respiratory viruses may compete between each other for different receptors. So all of those things are very interesting. And then in this article, for example, there is a nice table that tells you what type of virus is more prevalent during the year. And I like to see Moffitt, and because often we screen those patients, especially the more immunosuppressed, for many respiratory viruses, and I start seeing at Moffitt what's happening in the community. So it's very interesting. But winter viruses, classically influenza, RSV, and are those the classic virus for winter. The adenovirus is all year round, the same as coronavirus. Parainfluenza has 2 peaks, and it depends on the type of parainfluenza. And we're going to talk about the types of parainfluenza that there are. But the parainfluenza 3, it seems to be more towards the spring, and the parainfluenza 1 and 2 towards the fall. Human metapneumoviruses, late winter and spring, and of course rhinovirus all year throughout, and summer viruses include the enteroviruses. So let's start with parainfluenza. So it was interesting that parainfluenza was discovered in 1950 when the doctors start seeing a lot of kids with hacking cough and croup-like symptoms. And eventually, further studies discovered that the type of virus was parainfluenza. There are 4 types of parainfluenza viruses. The most clinically significant parainfluenza viruses are these 3, 1, 2, and 3. The type 1 and type 2 have been the ones that have been most commonly associated with croup. And the type 3, lower respiratory tract infections and pneumonias. For A and 4B, the clinical significance is not well described. Again, the type 3 is the one that is really important for severely immunosuppressed patients such as transplant and hematologic malignancy, patients with hematologic malignancies, prolonged neutropenias, etc. So this is another nice review article that if you want to dig more into it, you can look. So the virus, I wish I had more time to paint the different viruses, maybe next time, but it helps me to understand. So when you look at the viruses, they all have some proteins located in the outside or glycoproteins. So in this particular parainfluenza, you have the matrix protein that's in charge of building the virus. And then the H, N, and the F protein are important for attachment and replication of the virus. Most of the time, the immune system develops antibody against those 2 particular proteins. Unfortunately, because the viruses, the respiratory viruses in general, are prone to mistakes when they replicate, it's very difficult for vaccines to develop, and immunity wanes over time. These other are also some similar proteins that you can find in other respiratory viruses. So, as far as the clinical manifestations of parainfluenza viruses, it has 2 particular types of presentations. You can have upper respiratory tract infection, and like the one you see in younger kids, and the peak of the infection is usually by 6 years old, anywhere from 3 to 6 years old. Most of the kids who have had croup. Obviously, it can also cause otitis media, sinusitis, and conjunctivitis. Again, the type of virus that likes to cause this is the type 1 and type 2. Nobody knows exactly why. It may be something related to the receptors in the epithelial cells of the upper respiratory tract. And the type 3, parainfluenza 3, is the one that likes to cause more lower respiratory tract infection. And that's similar to the clinical symptoms that can be seen by RSV virus or human metapneumovirus. And it's, the peak for that one is usually by the age of 3. So for younger kids, it's very important. They can get really sick. The classical signs, and I don't know if you can remember from your own experience or if you have younger kids, the croup, patients who got croup, you know when your kid has croup. Because they come to me and say, Mommy, I have COVID. I say, no, that's croup. I mean, it's so clear. I mean, they hacking cough, and then they go, I cannot breathe. And you know. And I'll show you a figure of what happened in the upper airway of the kids. So parainfluenza virus accounts for 1 to 15% of respiratory infections in adults, and up to 2 to 11.5% of hospitalizations from respiratory viruses in adult patients, and that's more in elderly patients who are in the nursing homes. And it's a frequent cause of COPD exacerbation, particularly, again, older patients, and is usually the second or the third most common virus associated with COPD exacerbation. There are other clinical manifestations associated with parainfluenza virus, and that includes neurological, renal, and even rheumatological diseases. So this is what happened with the upper respiratory tract infection due to parainfluenza or croup, because it has the tendency to affect the upper respiratory tract area. You can see how this is a normal airway with the vocal cords. You remember when you were learning how to intubate, you see the vocal cords, how they move. And see how open or how big this area is. When you have a younger kid, the diameter is way smaller. So the area for the air to pass through is very small. And that's why you hear that type of cough, or the breathing is called stridor. And in X-ray, we see the typical staple sign. You see how narrow the airway is here. So in immunosuppressed patients or transplant patients, it can be really severe. It can cause severe lower respiratory tract infection, especially in neutropenic patients and transplants. The type 3, remember, the type 3 is the one that has a tendency to produce more lower respiratory tract infections. It's isolated in more than 90% of those cases. Pneumonia has been reported in 24 to 55 of the patients, stem cell transplant patients due to respiratory viruses, due to parainfluenza. And the mortality in this population can be as high as 50 to 70%. So it's a really, really important virus for this population. In solid transplant can also cause severe infections, particularly in lung transplants. On them, you can see graft failure, decreased respiratory function testing. And sometimes the problem with this type of viruses is that you can have a secondary infections. You can have Aspergillus, complicated infection. You can have CMV, and of course, other bacterial infections. And the way to suspect that is a patient who initially had the viral infection, tested positive, got a little better, and then got worse. So this bimodal distribution should make you think that there is something else going on. Also, radiologically, and I'll show you a CT, how it looks. If you, normally it's a patchy ground glass or centrilobular nodules, but if you see a dense lobar consolidation that follows that, or if the patient didn't had a bimodal clinical presentation or got significantly worse, and you repeat the imaging and you see that lobar consolidation, that's when you have to think in a superimposed bacterial infection. So this paper is from CID, and it's a patient, it's a different CAT scans of a patient with allogeneic stem cell transplant and parainfluenza. So and this other slide was from Dr. Green. This is nice because it helps you to visualize the typical nodule that you may see in some infections. So when you can see a random subcentimeter, very tiny nodules like this, or centrilobular. When you see these, you suspect viral infection. And this is perilymphatic nodules. That's more in a lymphangitic spread of malignancy. But these two is something like you could see in a respiratory virus on a CT. So, for example, this patient above has peribronchial nodules. You see all of these nodules around here. If you look over here, those are more like random nodules. And then here in the figure B, you see how those nodules coalesce all together, causing kind of like a consolidation, semi-consolidation. And the figure C is a very tiny, C, very small peribronchial nodules. The picture is not really, doesn't have the best quality. And here, there is multiple nodules, but you see an area of ground glass. So it's important to train your eye to determine what could be going on if the patient may have a viral infection versus a bacterial infection based on consolidation or nodule with halo that could make you think in a mold infection. But this is very classic of respiratory virus and very severe because this is a transplant patient, probably parainfluenza 3. So as far as the treatment, for group in kids, systemic steroids are superior than inhaled steroids. For adults, systemic steroids, the data is not very conclusive. The same is true for systemic ribavirin. Some articles say for transplant patients you may use it, some others no, but there is no really randomized control trials for ribavirin. But for stem cell transplant patients and hematological malignant patients with leukemias, for example, you can check the IV Ig levels, and if it's less than 400, then data has shown that IV immunoglobulin can be given in this particular cases. And then this is a new medication that is under clinical trials. That's 181. Supposedly has resulted in promising results in some transplant patients. It's a nebulized medication. I never use it here at Moffitt. So the next virus is RSV. This is another nice article, review article that you can read for more information. So a little bit about history. It was discovered in 1956 after a virus was discovered in 14 chimpanzees, and they have coryza type of symptoms. So it was first named chimpanzee coryza agent, but later was discovered to be mainly in humans or a human pathogen. Again, remember that it circulates typically during usually winter and spring, but sometimes fall. There are two types, type A and type B. And just know that up to 95% of the kids have been infected by the age of 2. So just like the other parainfluenza virus, so this virus has some proteins, glycoproteins in the surface. The fusion protein this one is extremely important. The attachment protein and the SH protein is also extremely important for the attachment, viral replication, and antibody production. So the clinical manifestation, it depends on whether the patient is getting primary or secondary infection, or if the age of the person or the patient and the immune system. So it's extremely important virus for younger kids. Sometimes neonatals can develop apnea. Nobody knows exactly why. For premature patients, not only bronchiolitis and pneumonia, but those premature patients can even have pulmonary fibrosis as a consequence, and other respiratory complications from severe RSV infection. It is the most common type of pneumonia radiologically seen in younger kids, younger than 2. And it's because the virus, for some reason, likes to infect the small airways. In adults or older kids, it can cause just upper respiratory infection with cough, coryza, can also cause conjunctivitis. It also can, just like parainfluenza, has been associated with COPD exacerbation, but this one is important. Even older adults can have short-term hyperactive airway or short periods of wheezing or post-viral kind of syndrome. In stem cell transplant, the mortality is extremely high. So this virus is really mean for transplant patients. The mortality can be as high as 100%. This is just a CT of a patient who had a RSV pneumonia 57 days after allogenic stem cell transplant. And you see these patchy kind of small nodules and patchy ground glass, and it's coalesced here in a consolidation. Just like with parainfluenza, sometimes those patients can have secondary infection due to bacteria, bacterial infections, or mold. The treatment in general for immunocompetent patients is supportive. There is a whole chapter for kids in the treatment of bronchiolitis. But in immunosuppressed patients, ribavirin and IVIG has shown to be effective. And we use oral ribavirin as opposed to nebulized because it's very teratogenic to protect the staff, so we use oral. Paramyxoviridae is an RSV human monoclonal antibody that has been shown to be effective in younger kids. The data for adults is not very conclusive, and it's used during the months of the peak of the virus to prevent infection. Of course, if the patient has asthma and COPD, you have to treat the asthma and the COPD as you would for exacerbation. And again, ribavirin is also not recommended for younger kids because the data is not conclusive, but it's basically for older adults that are immunosuppressed, transplant patients or leukemic patients. Remember that ribavirin is contraindicated in a pregnant woman, and if you're going to use it in a female that's immunosuppressed, you need to do a pregnancy test. So this just was a data about palivizumab preventing RSV in younger kids, younger than 2 years of age. This includes more than 3,000 patients, and it was given for 5 months, and it proved to decrease the hospitalization. So, moving to the next virus. This is one of my drawings. It's a charcoal. And what it illustrates is a Valentine's Day in 1918 during the Spanish flu. It's just very, those are different objects from the time, you know, all lamp and camera and a rose and rings and a mask, just like we use now. That time, patients were using masks also to protect. So, if you want to dig more into influenza per se, I recommend you to read this article. So influenza is still a heavy burden for our healthcare, particularly nursing homes and elderly patients. There are 2 types of influenza. We have influenza A and B. Influenza A is the one that is more prone to produce pandemics, and that's because it's more it usually causes drifts and shifts of the virus, and I will talk more about it in a minute. Influenza Influenza B, there are two subtypes, Yamagata and Victoria. Influenza C, it hasn't really been associated with a lot of clinical diseases or significant diseases, and influenza D primarily has been discovered in cattle. So influenza B is not very prone to cause pandemics, or not yet, because the virus mutates very slowly, and it only does in the HA protein, and I'm gonna discuss more about it, as opposed to influenza A. So in order to understand the virus per se, you need to understand that there are two important glycoproteins that are located in the surface. You have the hemagglutinin or H protein, and the neuraminidase or the N protein. The hemagglutinase is important because it helps the virus to attach in the upper airway in the sialic acid of the epithelial cell. Once it's attached, it can enter and release the virus. Eventually, when the virus is already formatted inside of the host and is ready to come out, the virus gets attached again to the sialic acid before it's cleaved to be able to infect other cells. And the cleavage of the virus from that sialic receptor is in charge of the neuraminidase. So we will see about the treatment, how some of the treatment options target this specific protein. So, like we were talking about, it's important to understand this concept and know why influenza A has been linked to different pandemics. So we talk about the proteins. We have the HA and the NA proteins outside on the surface. So those proteins can have minor changes or antigenic changes, or they can have major genetic mutations, and that's called shifts. When that happens, then you can have more problematic outbreaks or pandemics, even from the virus. And what happens is that the receptor of the viruses, that's usually avian or pigs, has different type of influenza virus inside, and the virus rearranged. And when the virus jumps from the pig or the avian to the human, causing a novel type of influenza, that's when a pandemic can develop. And that's why many researchers are constantly investigating the type of viruses that are in influenza viruses that are in the pigs or in the birds, because it could be a potential threat for humans. So the clinical manifestations for influenza, it varies. The patient can tell you exactly when it happened. When it was in the afternoon, I had a back pain, and then the fever follows. That's very classic of influenza. And this may or may not follow by upper respiratory symptoms. Patients may have just isolated GI symptoms, and that's more commonly seen in younger kids. And again, remember that influenza can have different complications. It can have secondary bacterial infections. If in the community you can see Staph aureus or strep pneumo, you can also see Moraxella, Haemophilus influenza, and again, bimodal distribution. Bimodal presentation with acute symptoms. They get better and they get worse. Patients may have myocardial infarctions, pericarditis, myocarditis, CNS complications, including seizures, encephalomyelitis, myositis, particularly lower extremities in younger kids, even more to immune reaction to the virus, and then parotiditis occasionally. It's important to understand what are the patients at high risk, because those patients are the ones that usually receive treatment when they're diagnosed. So older than 65, younger than 4 years of age, pregnant woman, and postpartum up to 14 days after delivering the baby, nursing home residents, of course, patients with cardiovascular diseases, renal diseases, HIV, cancer patients, and transplant patients. Also patients with a BMI more than 40. For some reason, Alaska Natives and American Indians are more prone to have severe disease. The treatment. So if you're not at high risk, the treatment is supportive. If you're at high risk, these are your options: oseltamivir, zanamivir, and peramyxovir, and also this one. These three target the neuraminidase. Remember, that's the protein that is in charge of cleaving the virus from the sialic acid. So these viruses can go freely and infect other cells. So what these antivirals do, they attach to the neuraminidase as if it was sialic acid, and the virus cannot get released. And this is a more new type of antiviral, and is in charge of, it blocks the viral replication. This is no longer recommended because of resistance, so we don't use it. There are a few cases reported resistant to oseltamivir since 2009, so it's something to keep in mind. Prevention, of course, vaccine. It's important to be familiar with the type of vaccines that are out there so you understand better this concept, because the patient will be asking you. But for influenza, the ones that we use the most are trivalent and quadrivalent. The trivalent has 2 strains of influenza A and 1 strain of influenza B. Quadrivalent has 2 of A and 2 of B. Those can be with adjuvant, or adjuvant is a particle that is added to some vaccines to make it more immunogenic. It's usually a chemical element, usually aluminum, phosphate, aluminum, potassium, to make the immune system more, to make it more immunogenic. And sometimes that adjuvant is responsible for some local type of reactions. And if you want to read more about the type of vaccines that are out there in general, you can go to these government websites and what are adjuvant vaccines, because it's added to different, not just influenza, but different type of vaccines. So the last virus that I'm going to talk about is human parainfluenza virus. Human parainfluenza virus, just like, metapneumovirus, is very similar to RSV, and it belongs to the same family. And it has these 3 important proteins: the fusion protein, the glycoprotein, and this hydrophobic protein. These 2 are in charge of the attachment and replication of the virus. This one is believed to be related to the evasion of the immune system. So if you don't want to read more about human metapneumovirus, you can go here and read this review article. But just know that most children are infected by the age of 5. They can have bronchiolitis, just like RSV. You can have asthma exacerbation. You can have upper respiratory symptoms. And again, there is a possible rule for asthma and COPD exacerbation, and it can also cause severe disease in transplant patients. The treatment is supportive. Ribavirin, there are some anecdotal trials with ribavirin, but because it could be so bad for transplant patients, we use it for transplant patients based on some in vitro and in vivo data. We also use IVIG for these immunocompromised patients. There are other medications that are under study, including fusion inhibitors. All of these, there are under extensive studies. So in conclusion, most respiratory viruses have a seasonal occurrence, particularly in the northern hemisphere. Severe disease, including lower respiratory tract infection and pneumonia, can be seen in very young kids, immunosuppressed, pregnant women, and transplant patients. Complications, including bacterial infections, can be seen with bimodal presentation or patients who just continue to get worse, particularly in immunosuppressed patients, in which we can also see secondary mold infections. Some of these respiratory viruses can be also associated with COPD exacerbation and asthma exacerbation. Remember that there are other clinical presentations, not necessarily outside of the respiratory tract infection, with some of these respiratory viruses, including CNS presentations, pericarditis, myocarditis, rheumatologic diseases. Unfortunately, because of those proteins that are outside of the viruses and how they change and mutate over time, vaccines represent a challenge. And antiviral medications, unfortunately, we are very early on in the development. Perhaps more options for influenza, but the rest of the viruses, we still have a lot to discover as far as treatment. And that's my last painting. And coronavirus and influenza, the two great pandemics of the last 100 years. Spanish flu, Influenza A, H1N1, and the COVID-19. Any questions?